Welcome to Transplant class. This 90-minute video presentation and discussion will address many factors with regard to transplantation for you, the patient who has end-stage renal disease. It is our hope that you will gain enough information to make a decision about whether or not transplantation is an appropriate way to treat your end-stage renal disease when compared to dialysis. However, I will not specifically address the mechanics of dialysis, the long-term complications and such, but will discuss dialysis when it can be compared to transplantation directly. After you spend the next 90 minutes watching this presentation, we would be available to address any particular questions or concerns you might have with regard to transplantation, as it's an open forum. One might ask before we start why we are presenting this class to you, and it serves two major purposes. One is it gives us an opportunity to provide you with all the relevant information for you to make a decision in one place, as well as affords us, the solid organ transplant program at Dartmouth-Hitchcock, the opportunity to demonstrate to the federal government, who underwrites the cost of transplantation, demonstrating that we are providing this educational material to you. By way of introduction, I'm Dr. Chobanian. I've been involved in transplantation since I finished my fellowship in kidney disease and initiated my transplant experience at the University of Wisconsin. I came to Dartmouth in 1997, where I soon became the medical director of transplantation and more recently the program director of transplantation here at Dartmouth-Hitchcock. Let's go to the purpose of the talk. By the time you leave this afternoon, you will answer these questions in part based upon your understanding. What are my options when and if I have kidney failure? If I choose to receive a transplant, what are the risks? And what do I have to do to become a kidney transplant recipient? Let's go to the first question. What are my options when and if I have kidney failure? When one considers dialysis, it's important to understand that there are two forms of dialysis, hemodialysis and peritoneal dialysis. The best that dialysis can do is replace about a third of your filtration ability of your native kidneys. That's when your native kidneys were working 100% of normal. And that's only if you get hemodialysis 5, 6, or 7 days a week. We have this kind of knowledge based upon many countries throughout the world that cannot afford transplantation and leave their dialysis units open 24 hours a day. One of those countries is Taiwan, which is an island off the coast of China. Published information coming out of Taiwan demonstrates that dialysis 5, 6, or 7 days a week can replace about a third of your filtration ability. It does increase your longevity by about 10%. The differences in longevity between hemodialysis 5, 6, or 7 days a week or peritoneal dialysis are negligible. However, we know that peritoneal dialysis cannot be accomplished by everybody. You might ask what hemodialysis 3 times a week affords you. it affords you about 20% of your filtration ability. And by so doing, it extends your life, but not nearly as well as if you had physiologic kidney function. That's what a kidney transplant can do for you. A kidney transplant will replace anywhere from 50 to 60 to 70% of your kidney function. Notice I didn't say filtration. It does filtration, but so many more meaningful processes, such as providing you with erythropoietin or EPO or active vitamin D or other facts in terms of glucose regulation and the like. I'm also amazed the number of times in my long career that a single kidney transplant can function above 70%. And many transplants function at 80 or 90% and rarely above 100% of normal. And that's right, one single kidney working as if it was two normal kidneys. There are several situations where that might happen. First would be placing an adult kidney into a young child, or placing a male kidney, which has 20% more functional capabilities than a female kidney does, into the female recipient. This means you'll have improved quality and length of life. It does require major surgery and lifelong immunosuppression. And unfortunately, if you don't have a living donor, you're going to have to wait for your kidney transplant. This is the most important slide that you'll see today in this presentation. You might have thought about this before you were driving to our medical center, or you were starting this slide presentation. This slide answers one very important question. Do you live longer if you get a transplant? Whether it's in the table for non-diabetics or diabetics, you can see that a transplant will extend your life over dialysis in each age group, no matter how old you are. You could see that as you get older, the differences are narrowing, but still, transplant provides the opportunity to extend your life. And that's why we do transplant. And that's why, in 1984, the federal government began underwriting the cost of transplantation. What diseases cause kidney failure? Well, as you can see in this particular slide, that the graph demonstrates that diabetes is far and away the most common cause of kidney failure in the United States between the years of 2006 really to the present. Then hypertension, other causes such as losing a kidney because of cancer, or familial disorders, or urologic problems, and then inflammatory diseases, and lastly, cystic kidney disease, such as autosomal dominant polycystic kidney disease. I put this slide up here because it's unique here in northern New England that the second most common cause of kidney failure after diabetes is in fact cystic kidney disease. Let's talk about transplant. There are two types of transplants, a living donor transplant or a deceased donor transplant. A living donor is any willing person that is 21 years of age or older and generally less than age 65. That living donor doesn't have to be a relative, and it could be any particular acquaintance as long as no money has been exchanged, no services or goods provided, which is illegal in the United States to buy and sell organs. If you are lucky enough to have a living donor, that means you will get to your transplant earlier. That means you'll be healthier at the time of transplant, and these kidneys do last longer than deceased donor kidneys. I'll talk about how long kidneys last in a minute. Disadvantages for your particular donor: there is a risk to the donor. That risk is minimal, 1 in 11,000 chances of dying during the procedure. That's called the anesthetic risk. Also, as a disadvantage, it can be difficult to ask for a kidney. But I've found that the greatest obstacle to getting a kidney from a living donor is the fact that you, as recipients, are not willing to discuss your health openly. And frankly, there are no mind readers out there for potential donors. You need to be open about discussing your need for transplants without creating any pressure. And I'm supposed to tell you there's pain and suffering for the donor. The greatest problem that I have experienced is that donors have a difficult time with regulating their bowels after the surgery itself, and that's because we use narcotic pain medications during the recovery period. If you don't have a living donor, you must wait for a deceased donor, and that's determined by the waiting list. Current wait times here in 2020 can be as short as 3 years or as long as 10 years, depending upon your blood group. Advantages to receiving a deceased donor: well, there are no risks to these donors. These donors are either brain dead or their hearts will stop after support is withdrawn. If you're a diabetic and qualify for a pancreas transplant, it is almost better to receive the pancreas and kidney transplant from the same donor, unless you have a living kidney donor. We do not use living pancreas donors for transplant. Disadvantages to receiving a deceased donor kidney: these kidneys don't last as long as living donor kidneys, might not work immediately because they can be transported as far away as Alaska, during which time that kidney is placed in an ice chest and cold and without blood to supply it enough oxygen and nutrients for it to work constantly. And what we're seeing is most older people donate their organs once they're either declared brain dead or their hearts will stop after support. This is a little bit more difficult to interpret as a slide, but it provides information that comes up in talks that I've given throughout the years. And the big question is, how can anyone be assured that the donor organs are safe and would not pose a risk for demise in the recipient? You should be assured that your potential deceased donor organ has been tested for everything humanly possible and every possible infection. We use what's called nucleic acid testing, which is very specific. That test is sensitive in that it gives only false results 1 out of 550,000 times. And the test is accomplished several times during the period where the potential deceased donor is identified and organs are allocated. This particular slide also states that it doesn't matter what is the cause of death among organ donors, because no matter what the cause of death is, the organ itself lasts an equal amount of time no matter what the cause of death was from the deceased donor organ donor. It's important to realize that your risk of contracting a life-threatening infection is lower than your chances of dying from a car accident today. And with that in mind, you should try to worry less about understanding everything there is to know about each and every donor. What about the wait list? Well, the wait list is determined for people who don't have living donors. As an aside, you should be aware of the fact that your living donor could have blood group O or your blood group. If you're blood group A, for example, your living donor could have blood group O or blood group A and still be compatible. And that's same for blood group B, or if you're lucky enough to have blood group AB, you can receive any living donor organ. However, for deceased donors being placed on, waiting for a deceased donor organ and being placed on the wait list, O recipients can only receive an O deceased donor kidney. A and AB recipients receive only an A deceased donor kidney, and recipients with blood group B only receive a B deceased donor organ. In December of 2014, the federal government changed the way they allocated organs to you, the potential recipients. They created two scores, an EPTS score, or Estimated Post-Transplant Survival Score, or a KDPI score, also referred to as Kidney Donor Profile Index score. These scores are based upon a number of factors, including age, diabetic status, prior transplants, or time on dialysis. While you're waiting for a kidney transplant, you will be seen every 6 months to check on your health and to maintain adequate health to get ready for your transplant. This graph demonstrates that EPTS score and recipient longevity varies between the different percentiles. EPTS scores between 0 and 20 have the best outcomes, and as you can see on this graph, more than 90% of patients who have an EPTS score will live for more than 10.5 years. As you could see, those with scores of 81 to 100%, only about 35% of patients will live more than 10.5 years. And thus, you might imagine that the younger you are, the lower your score, and the older you are, the higher your score. There are other factors for organ selection. One of those factors is considered how much time the kidney or pancreas has been out of the deceased donor's body without any blood supply. And as you can see, if you try to transplant a kidney after about 36 hours, it's very likely never to work. We here at Dartmouth pride ourselves in transplanting virtually 100% of our kidneys within a 24-hour period, thereby maximizing the opportunity to have that kidney transplant work. This is the second most important slide you will see today. How long does a kidney transplant last? Or in other words, can it vary with KDPI score or Kidney Donor Profile Index? As you can see in this bar graph, a living donor kidney on average lasts about 12.5 years. A kidney from a deceased donor who's ranked between 0 and 20 will last about 11.5 years. The average kidney transplant lasts about 9 years, and a kidney transplant that is ranked above 85% will last about 5.5 years. Half-life refers to the concept that half of the kidneys will function up to that point, whereas the other half of the kidneys will last double that amount. So in general, living donor kidneys last about 20 to 25 years in at least half of the patients. You might be thinking, why would I ever consider accepting a deceased donor kidney that has been ranked above the 85th percentile? Because it only lasts 5.5 years. Well, this is an interesting fact. If your kidney transplant lasts a mere 2 years, you will have washed away the history of having been a dialysis patient. And that's important because each year you're a dialysis patient, you have a 7% chance of dying. And it's cumulative. 10 years of dialysis infers that you have a 70% chance of dying that year. And And thus, people who have been on dialysis for quite some time have many antibodies, have other factors that would prevent them from getting just any kidney transplant, would be wise to consider accepting a kidney that is ranked above the 85th percentile, especially if you don't have a living donor. This graph exemplifies the different percentiles for KDPI scores. And again, as you can see, the kidney that is ranked between 0 and the 20th percentile in light blue, you can see that at 10 years out, more than 70% of those kidneys are still functional. Whereas if your score is greater than the 85th percentile, only about 30% of those kidneys are functional. How do we do at Dartmouth-Hitchcock? Well, you can basically add anywhere from 2 to 5 years to all those projections. And that includes even at 20 years out. The national average to keep kidneys lasting more than 20 years is essentially less than 10%. In our program, it hovers in the 15 to 20% range. We were the very first program to avoid using steroids or prednisone, in particular, in 1997. By 1998, we became the first program in the United States to minimize immunosuppression by using only one anti-rejection drug long term, and that drug is called tacrolimus. We have a very low rate of complications. Since 1992, at the inception of this transplant program, there has only been 2 cases of post-transplant lymphoproliferative disorder. PTLD is a type of a lymphoma that is driven by a specific viral infection called Epstein-Barr virus. As you can see, the annual rate nationally is 20%, or 1 out of 5 people. We have been involved in more than 1,000 transplants, and we only have 2 cases of lymphomas. We also have a very good opportunity to protect you from your original disease in case you had an inflammatory disease such as lupus, and we lose very few grafts to recurrent disease. What I'm most proud about, though, excuse me, is that we have the lowest rejection rate in the United States. Our current rejection rate is less than 1%, and specifically 0.6% rejection rate, and that's an average of more than 20 years. As you can see, the national average rejection rate hovers between 12 and 24%, with or without antibody inductions. You might ask why it's so unusual that we have such a low rejection rate. Well, when I came to join the transplant program at Dartmouth-Hitchcock in 1997, I realized very quickly that the catchment area that we follow, in other words, the citizens of both New Hampshire and Vermont, are generally all Caucasians. If you look at the national census from 1990, 2000, and 2010, 98 to 99% of the population is Caucasian. Now, without any concern of racism, it's important to understand that African Americans and Hispanics have a quite robust immune system. And by that I mean they want to reject their organs. And that has nothing to do with socioeconomic problems. In fact, there have been some genes identified that demonstrate that their overactive immune systems are probably related to the evolutionary changes that occurred from living in Africa forever and being exposed to all those infections. And thus, when I realized in 1997 and 1998 that most of our donor organs were originating from these 2 states, it became obvious that we could minimize immunosuppression without risking rejection. And thus, we became one of the earliest programs in the world to minimize immunosuppression successfully. This particular slide is an official government slide for data that pertains directly to our program here at Dartmouth-Hitchcock. It is from the Scientific Registry of Transplant Recipients, including those that are on the wait list. It is a requirement that I go over this slide with you. We will refer to it as the blue bar graph slide, and you will be asked to sign a form that we send into the federal government that said that Dr. Chobanian went over the blue bar graph slide with you. As you can see in figure A1, we had 92 people waiting on the wait list between 2017 and 2018, dropped to 88 people on the wait list between 2018 and 2019. You could see that those individuals that are active on the wait list and can receive a transplant are greater than 50% of the total on the wait list. This is important because if it was less than 50%, one could become suspicious that we list people without actually evaluating them and don't deserve being on the wait list. And some programs add people to the list without any formal evaluations. This is not legal to do. As you can see in table A1, we did 16 transplants between 2017 and 2018. It increased to 22 patients between 2018 and 2019, and that's because before 2017 we had lost our transplant surgeons. We are now fully operational with our director, Dr. Daly, and his associate, Dr. Zimmerman. In figure A2, you could see that the government expects us to do approximately 27 kidneys in a year. We actually only did 22 over a 2-year period, and we should be doing about 15 deceased donor kidneys, whereas we only did about 6. And this again was because that we did not have the full number of transplant surgeons necessary to be available 24 hours a day, every day of the year. The government says we should lose more than 4 people on the wait list every year, or correction, every 2.5 years, correction, 2 years, whereas we lost a little bit more than 3. And that's because we have an older age population here in the northern New England region. In figure A4, it demonstrates that we should lose 1 kidney transplant during a 2.5-year period, where in fact we did. And generally that's because the graft failed due to complications associated with an older individual not being able to perfuse the kidney adequately. The government says we should have 1 patient die during a 2.5-year period after transplant, but we had no deaths during that time period. To receive more information about other programs, I direct you to this website for the SRTR. It's very interactive, and if you have any questions with regard to how to navigate that website, please feel free to call your transplant coordinator, Laura Galloway, at the above number. Let's go to the next question. If I choose to receive a transplant, what are the risks? In general, there are 5 major risks to getting a kidney transplant. Rejection, which, as I stated before, is rare here at Dartmouth-Hitchcock. Cardiovascular or heart disease, cancer, infections, and bone problems. Before I go into each of those categories, I think it's important to review this particular slide. This slide actually is a summary of a manuscript that was submitted and published from the New England Journal that demonstrated the cause of why kidney transplants fail. The individuals in that paper reviewed data from the SRTR and found that 50% of kidney transplants are dysfunctional after a certain period of time. And the reasons for their dysfunction are chronic rejection, drug toxicities, recurrent disease, new kidney diseases, or acute rejection. 30% of those patients we believed could ameliorate or correct their problem of kidney transplant dysfunction through minimizing drug toxicity, preventing recurrent or new kidney diseases, and of course preventing acute rejection. And so in our program, if the kidney is dysfunctional, it'll be because of chronic rejection. However, the most common cause of losing a kidney transplant at Dartmouth-Hitchcock is in fact death of the recipient. And how are these patients dying? Heart disease, infections, cancers, among other causes. Now, let's go to the first risk, rejection. As I stated, rejection is rare at Dartmouth-Hitchcock, and that's because we use specific induction schemes as well as specific maintenance schemes. What do I mean by that? Induction infers that you're prepping the transplant recipient before the transplant is going in. We use 3 induction biological compounds: alemtuzumab, thymoglobulin, or basiliximab. Each of these substances, which are biologically formulated, are given prior to the transplant receiving blood from you. And what that does is it renders your immune system inactive until a certain period of time when you could reactivate your immune system, but only to a degree that you wouldn't reject your kidney. We use steroids or high-dose solumedrol, a relative drug to prednisone, for 3 days to control inflammation acutely. If you remember a gentleman by the name of Gary Coleman, who was in a television show called Different Strokes, he was on steroids every day to try to prevent his primary disease from coming back in his transplanted kidneys. I believe he had 3 kidneys in his lifetime and unfortunately died in his early 40s, complications of dialysis. We were the first program in New England to stop using steroids. And for the life of the kidney, also called maintenance drug therapy, you could be on 3 medications, that's less than 1% of our patients, 2 medications in about 60% of our patients, and the rest are on 1 drug. The 3 drugs would be prednisone or steroids, tacrolimus or Prograf, Cellcept or mycophenolate mofetil. Each of these drugs has a specific role to play in controlling your immune system. The main drug that we use is Prograf or tacrolimus or Invarsus. All other drugs are the same, but different formulations. These drugs have side effects. Notice that some of these drugs can cause kidney damage to your transplant. In our program, we try to minimize that by using a heart rate control medication called diltiazem, which competes for the metabolism of the drug and allows us to use 1/5 the total daily dose that you would normally use of that anti-rejection drug. As you can see, the national average for kidney damage from tacrolimus is 17%, and here at Dartmouth, less than 6%. They can cause tremors, hair growth in men, hair thinning in females, high blood pressure, diarrhea. It can increase your chance of getting an infection or cancers. It can cause bone damage or cosmetic changes such as prednisone. You can develop post-transplant diabetes, although you never had true diabetes before the transplant. It can cause weight gain and high cholesterol, psychological problems, growth impairment in children, cataracts, hormonal change, and poor healing, among other less common side effects. I bring your attention to post-transplant diabetes. We have now learned that post-transplant diabetes occurs in kidney transplant recipients who did not have diabetes as a cause of their kidney failure, however, did have a family history of it, possibly gestational diabetes during a pregnancy, or had glucose intolerance while they were in kidney failure. These are the individuals that have a higher risk of developing diabetes permanently after getting a kidney transplant. In our program, less than 5% of people develop diabetes after transplant. The next risk is cardiovascular disease. Each year that you have a transplant, you have an 8 to 10% chance of a stroke or a heart attack after your transplant. This compares to a risk of 25% for just being a dialysis patient. However, if you add other risk factors such as having had a previous heart attack or a stroke, having diabetes, having tobacco abuse, high cholesterol or high blood pressure, you add all those risk factors, including family history, and the average dialysis patient has a 72% chance of a risk for a heart attack or a stroke on an annual basis. So, you can do something today. You can stop smoking. That's not easy to do, but there are many programs, especially one in Vermont, which uses behavioral modification with great success. More than 70% of patients starting and completing the behavior modification program to stop smoking through the state of Vermont are successful. You should get blood pressure control. There are many medications, there's exercise, there's sleep, there's eating correctly, there's stress reduction, and many other factors that control your blood pressure, which can help you to do better. Watch what you eat. Eat a heart-healthy diet. If you don't know what a heart-healthy diet is, you will be meeting a dietitian that can help you to understand that. In general, that's a no added salt diet or low salt intake, as well as low saturated fat diet. Take an aspirin if you're over age 50. This is controversial, and that's because many doctors misinterpreted a recent paper which demonstrated that aspirin in normal people over age 50 have excessive numbers of bleeding episodes associated with taking aspirin. That's not the group that should be on aspirin. However, as a renal failure patient or a transplant patient, you have a higher risk of a stroke or heart attack. By taking 81 milligrams of aspirin every day, you will minimize your risk of stroke or heart attack by as much as 40%. Treat high cholesterol. There's diet, there's medications, and there's increased exercise. 20 to 30 minutes of physical activity every day. Remember that your heart and your cardiovascular system is wrought with muscles, and those muscles are important to maintain the integrity of your cardiovascular system. So 20 to 30 minutes of some form of physical activity, even walking, is considered good for your cardiovascular system. If you're overweight or obese, it's time to get serious about weight management. If you need instructions and help on that, our dietitian will help you with that as well. And lastly, if you're a diabetic, you have my greatest sympathy, because diabetic control is a very difficult proposition. You have to try to get your hemoglobin A1Cs less than 7%. A hemoglobin A1C of greater than 10% means that you're not making an effort. And that's very important because your risk of recurrence of diabetes in your transplant is very, very high. The next major risk is an infection. You can get any infection that anybody else can get, but unfortunately common infections such as pneumonias or skin infections can progress rapidly to develop sepsis as well as bacteremia and seed different parts of your body and become life-threatening. You can get a rare infection that can reactivate. Everyone now knows that shingles is essentially reactivated chickenpox. I'm going to ask you today to get your shingles vaccine. No shingles vaccine, whether killed virus or attenuated live virus, is a good vaccine to get after transplant. Get it now. before you get your transplant. And the last infection is a very rare set of infections that can be transmitted by the kidney donor. We discussed HIV, we discussed Hep C and Hep B as possible life-threatening infections, but these particular infections, including BK virus or polyomavirus, mononucleosis or the teenage kissing disease virus, and its cousin cytomegalic virus, are all so common in the general public that your donor likely would have that virus. And if you're one of the 10% that doesn't have that virus, we still have to give you those organs. Fortunately, there are ways to control those infections. The best way to prevent an infection is early recognition. We have a policy here at Dartmouth-Hitchcock that if you get a fever, it is a medical emergency no matter when you might acquire that fever. And so you should talk to your primary care doctor now to see if he or she would see you immediately upon identifying that you have a true fever. Don't forget what your mother said, wash your hands before you eat. But you should also wash your hands after you eat. You should wash your hands before you go to the bathroom and after you go to the bathroom. And you should take a shower every day. We do not recommend taking baths. We don't recommend going into hot tubs or saunas or any swimming in dammed up rivers or lakes that are created because of dammed up rivers. In fact, we know of only several lakes in both Vermont and New Hampshire which are rock bottom lakes or glacier lakes. One is Lake Champlain, another one is Squam Lake, and Lake Winnipesaukee. And you can swim in the ocean. However, don't think that you can beat ocean waves because they can injure your kidney. Here at Dartmouth, we use less immunosuppression, so we see less infections, but don't let that be your crutch. Due diligence is very important. Notice on the lower right-hand corner, you see influenza vaccines and other killed vaccines. The government demands that you will get an annual flu shot. Our hope is that we'll have a COVID-19 shot vaccine available in the near future, and hopefully it'll be a killed virus. If you don't get a flu shot and you end up getting influenza, whether A or B, you have a 40% chance of dying from flu. Therefore, it's imperative that you get a flu shot annually. Only those individuals that have allergies to the vehicle are exempt from getting flu shots. The next major risk is cancer. The major cancers that transplant patients get preferentially over the general public are skin cancers, which can be basal cells, melanomas, or squamous cells. They occur in up to a third of all transplant patients, but up to a half of all Caucasian transplants. By using SPF 50 or greater sunscreen daily, every day, 365 days a year for all exposed areas of the skin, you can prevent skin cancer. As I stated, lymph tumors or lymphomas are associated with PTLD or post-transplant lymphoproliferative disorder, and we know that that risk is very much lowered by using lower doses of immunosuppression, as we see here at Dartmouth-Hitchcock. There are minimal increases of other types of cancers, all types of cancers, and so therefore it's most important to understand that your screening for cancer is very different than the general population. In fact, screening starts with you. We expect you to do self-skin exams every month, looking for lesions that are growing, changing colors, or bleeding. All women should do breast self-exams and check for lumps and bumps. All men should check their testicles for change in size and tenderness, as well as checking for lumps and bumps underneath your arms, in your groin, and yes, near your rectum. All women should have annual gynae exams with a pap smear if they have cervixes. If they don't have cervixes, they will need vaginal smears. All women should have mammograms, and that could continue indefinitely as long as you want that mammogram to be performed. And everybody over age 50 will get a colonoscopy every 3 to 5 years, not every 10 as stated for the general public. because your risk of cancer, whether that be colon cancer, breast cancer, gynecologic type cancer, or testicular cancer, is higher than the general public. The last risk is bone disease. As you are listening to this talk or attending a class and you have kidney failure of any degree, you have bone disease. In fact, the bone disease of kidney failure starts when you have approximately 85% normal kidney function, or in other words, you've lost 15% of your kidney function. You develop a type of bone disease. That bone disease progresses over time, and by the time you lose 65% of your kidney function, or you have 35% remaining, you now are well into a dramatic bone disease called renal osteodystrophy. When I came to Dartmouth-Hitchcock in 1997, stopped using steroids, focused on your bone health, I eliminated the risk of a pathologic or spontaneous fracture occurring. I have many stories to tell you about patients who got their transplants who had not focused on their bone health and developed pathologic spontaneous fractures from simple things such as walking down a set of stairs or closing windows. However, more importantly, bone disease and the inherent underlying causes also play a major role in how well you will do with your kidney transplant. This next slide demonstrates a paper that was written in 2015. It's a study of more than 3,000 transplant recipients, where the investigators chose individuals whose PTH or parathyroid hormone levels were greater than 200 prior to transplantation. And what they found in that group of more than 3,000 patients is that 46% of those patients died within 2 years after getting a transplant. In addition, 85% of those patients lost their kidney transplants within 2 years just because they had a parathyroid level prior to transplant of greater than 200. You might ask what that means for you. Well, we know how difficult it can be to control your PTH, and so we ask you specifically to make sure that your PTH is at least less than 400, because we're aggressive about controlling it after transplant as much as you should be aggressive about trying to control it before transplant. Right now, as you're in kidney failure, you might receive a monthly report card, and every 3 months you get a PTH level. Try your best to keep your PTH 200 or less, but if you can't, we will still transplant you if it's less than 400. Keep your calcium at 9.5, give or take 0.5. Keep your phosphate 6 or less, and make sure you're on active vitamin D. The last question of this presentation: what do I do to have to become a kidney transplant recipient? Well, the first step you took was listening to this talk. Now, you will undergo a medical evaluation, a surgical evaluation, social work, dietary, financial advisor, pharmacy, and our coordinators will help you to undergo special testing so that you can qualify to be active on the wait list. That is true for both living donor recipients and deceased donor recipients of kidney transplants. Your workup essentially is healthcare maintenance. All women will undergo a Pap-Gyne exam, all women over 40, mammograms, all men, prostate evaluations, all patients over 50, colonoscopies, and we're talking about the real colonoscopy, not stool samples or virtual colonoscopies. All diabetics and essentially all patients greater than 50 will have stress testing of their hearts. You will also have to undergo a dental evaluation for any active tooth decay and or gum disease. Unfortunately, the federal government does not support dental treatments and that will unfortunately be an out-of-pocket of expense for you. You must have a strong enough heart and good enough lungs to undergo transplantation. As you can see, you might need a formal cardiology or pulmonary specialist to consult on how to get you functional. Get ready to urinate. You'll be voiding between 2 and 3 liters daily for at least the first 3 to 6 months. If you have problems with your bladder, we'll have to make sure that we can figure out a way to help you to have a better bladder functioning. If you have recurrent urinary tract infections, they'll have to be investigated. For men with prostate issues, you'll have to have that addressed. And if you have dysfunctional bladder or incontinence, we might be forced to do alternatives for you. If you have an underlying history of substance abuse and it's still active, you can't be transplanted. You would have to have a period of substance-free abuse to be transplanted. And lastly, for this particular slide, if you have significant mental illness, you cannot live alone. You must have a friend or a relative that will be living with you to help you to take your medications routinely. The youngest patient we've ever done is 8 months, the oldest 84. We used to worry about body mass index. We do worry about the lower number. If your body mass index is less than 18, you might have a form of anorexia. And we know that anorexia leads to poor transplant outcomes with regard to both the patient and the kidney itself. The upper limits of body mass index really are determined by how big your abdomen is. If it's too big, it could certainly crush the vein of the transplanted kidney, because kidneys are placed in the anterior aspect of your body, not in the back where your own kidneys are. In general, you can have approximately 4 transplants in a lifetime. Again, you have to have a strong enough heart and good enough lungs to oxygenate that kidney. You have to have adequate blood supply to your legs, because the connection between your donor kidney and you will be made through blood vessels attached to blood vessels from your legs. You must be compliant with your medical therapy, especially in terms of visits, dialysis sessions, as well as taking your medications. You have to have some form of support from families or friends. You can't live alone. And lastly, you must have some form of financial support through insurances. The vast majority of patients are Medicare patients as well as Medicaid patients. If you have private insurance, that's also good, but we would suggest that you consider Medicare. This is a in-depth slide that says Dartmouth-Hitchcock is a Medicare-approved center. Being a Medicare-approved center, we are under strict regulations. And this would help you with regard to your medications as well as care of your donor. Only Medicare covers your donor's complications from the donation procedure throughout the rest of their life. And that's even if you die before your donor does. Only Medicare does this, not Medicaid or private insurance. It's also equally important to understand that if you go to a center that is not Medicare approved, who do you think will have to pay for the transplant? You will. Your insurance will pay for the living donor's evaluation. I think it's very important that you consider that, okay? Because Medicare has the broadest expanse of covering all the needs of the transplant world. Each week we meet twice a week to discuss your progress in your evaluation. We discuss whether or not you're ready to be activated on the wait list, and the committee comprises of our team, the coordinator, myself, the transplant physician, our surgeons, social worker, pharmacist, dietitian, and financial person. Your transplant coordinator will help you to collect all the information necessary to provide us enough information to guide exactly what kind of testing is required for you to become active on the wait list. Our coordinators will communicate with you directly as well as your caregivers, and we will work to complete your evaluation and eventually become active on the wait list through them. You will be notified if a particular test demonstrates that you have a new medical problem, such as a stress test that shows that you might have coronary heart disease, or a colonoscopy that suggests that you might have cancer. These all have to be addressed prior to your transplant. Okay? If the transplant team determines that you're not a good candidate, you will have a formal letter stating so. If you have any particular questions about that, you can contact us and appeal to CMS. Likewise, if you're active on the wait list and your health status changes, you must notify us so that we don't consider you for transplantation during the time that you're recovering from your medical condition. With regard to organs and where they're placed, we must follow all the regulations of UNOS, United Network for Organ Sharing, which is the national organization that distributes kidneys and pancreas and other organs to the appropriate people. It's important to note that you can only be listed at one transplant center throughout the region. Region 1 is all of New England except for the University of Vermont. And so if you're interested in being listed at Mass General, you can't be listed at Dartmouth. If you're listed at Dartmouth, you can't be listed at Mass General. And there is a reason for that. We all share the same donor pool. You can certainly be listed in one of the other 11 regions throughout the United States. The operation itself is completed under general anesthesia. A catheter is placed in your bladder, and you'll have lines placed to receive antibiotics, antiviral drugs, anti-rejection medications, your induction agents, as well as your maintenance medications, and IV fluid. The incision can be down either lower abdomen or down the middle if you're going to receive your kidneys attached to your aorta. Generally, you stay in the hospital for 4 or 5 days. More specifically, you can see in this diagram that the donor artery is hooked to the iliac artery that leaves the aorta down either the right or left leg. Then the donor renal vein is attached to the iliac vein that brings blood back from your foot and lower leg back up through into the inferior vena cava, up to the superior vena cava and back to your heart. Once those two anastomoses are made or connections are made, the clamps are taken off, and the hope is that the donor kidney is making urine, which is sterile. The surgeons then place a ureteral stent in the ureter, and that stent will stay in place for 4 to 6 weeks. The ureter is then sutured to the top of the bladder. Your ureters from your native kidneys insert in the bottom of the bladder. Complications of the surgery itself: bleeding, infections, urine leaks, fluid collection around the kidney, or also called a lymphocele, neuropathy or pins and needles sensation on the top of your leg, rejection, no one can guarantee that your kidney will work, and death, just like a donor, approximately 1 in 11,000 times. This particular slide demonstrates a number of factors. One, and important factor, is the fact it doesn't discriminate based on race, based on age, socioeconomic condition, or sex. There are a number of famous people who have received transplants. I bring your attention, though, to the top picture, which I added to this slide, of a black and white photograph of 2 individuals that are identical twins. In 1954, The gentleman who was sitting in the wheelchair became ill from a strep infection. The strep infection caused his immune system to attack his kidneys and cause him to go into kidney failure. His primary care doctor was quite concerned because he knew that in 1954, people who went on dialysis lived for approximately 6 months. His brother, his identical twin, refused to accept that consequence and asked his primary care physician why he couldn't donate a kidney. When the primary care physician investigated transplantation, he realized that it was completely experimental and not successful. But he also read a manuscript that demonstrated that skin grafts between identical twins in burn victims were very successful and very promising. And so he called his friend up at the Brigham and Women's Hospital in Boston, Dr. Joe Murray, who at the time was a plastic surgeon, and asked his friend why they couldn't accomplish a transplant between identical twins. Dr. Murray said, well, by all means, why couldn't they accomplish a transplant between identical twins? And so Dr. Murray undertook that process and completed the first successful transplant in the world in 1954 at the Brigham and Women's Hospital in Boston. How long do you think the recipient lived? Well, the recipient lived 8 years. He did not die because of kidney failure. He died of a massive hypertensive stroke. How long do you think the donor lived? He lived until his late 80s and lived here in New Hampshire as a farmer. And he was a spokesperson all of his life for donation. This last slide has the names of all of our team, whether it's the donor team, pre-transplant team, post-transplant team, transplant physicians, including myself, our surgeons, our social worker, dietitian, financial service person, quality coordinator, and our transplant administrator. We are grateful for having you join us today, and our hope is that you will take that next step to begin to consider transplantation as a preferred alternative to treating kidney failure. Thank you.